Hello, my name is Miles Leslie. I'm an assistant professor at the School of Public Policy at the University of Calgary and also appointed inside the Community Health Sciences Department at the Cummings School of Medicine. I was fortunate enough to join a senior colleague, John Connolly, on a grant in the COVID-19 rapid response cycle in February of this year. And that grant focuses in on and draws a multidisciplinary team of human factors, infection prevention and control, ethnography, sociology, practitioners together to work alongside clinicians and policymakers to understand and improve our responses to the pandemic. The research itself took three possible sort of fields of interest. That is to say, acute care, the hospitals, primary care, your family doctor, and the public health apparatus inside Alberta. Each one of those is a specific sort of domain and place that we could watch what was happening as people communicated policy to one another. The bigger idea behind the research is that policy comes from a place, is understood, repackaged, and then transmitted on to another place. That repackaging and transmission may simply be a pass-through, or it may also be a point of implementation where people have to figure out how to make what's been said on high real on the ground. I'll just walk you quickly through the three areas where we did that work. Again, we'll start with public health. Public health in Alberta is both a Ministry of Health and an Alberta Health Services responsibility. If you were tuning into the afternoon press conferences, that is Alberta Health's Dr. Dina Hinshaw, the Chief Medical Officer of Health for the province. Other medical officers of health at the regional levels, it's not actually regions here, they're called zones, but those people, doctors work inside of Alberta Health Services. It's a small point, but I make it mostly to point out how in that telephone game or communications piece of how policy comes into the province and then goes down and either out into Alberta Health Services or remains in AH and then actually goes to the front lines. That's what we're interested in trying to follow. We had a victory inside our work there. Our work is not predicated on just doing observations and studying how the policy is being communicated. Instead, our work is trying to assist and improve those communications. And inside public health, we were able to identify a number of areas where information was not working and not flowing the way people had intended it to flow. And so implementation was much harder than it needed to be. So we fed that back into the system in real time and adjustments were made so that flows improved. At the acute care level, inside the hospitals, our team of human factors experts and sociologists and infection prevention and control specialists have worked together with units that were told, sometimes with only hours worth of notice, that they would be transitioning into COVID care to come up with the safest ways possible to do that new work. And in the primary care world, we've been working with primary care teams across the province in rural and urban situations to come up with, similarly, ways that they can deliver care and manage the pandemic in the community, because this is where we know most of the management is being done. That particular technique that we prototyped and brought in from another application is called tabletop simulations. And those simulations have led to broad recommendations that can be applied across all of primary care, and also individualized feedback for each one of the clinics that we've been dealing with one-to-one in the sessions.